CataractCoach.com, taking pride in your routine surgery. Remember, too, the incision and the capsulorhexis are your signature. Let me show you a complete case start to finish. It's important that you keep in mind that 90% or more of what you do will be routine cases. So you really have to take pride in that routine case. I know for YouTube videos and for CataractCoach.com videos, it's more fun to watch these very unusual, crazy cases and see the absolute amazing intraocular acrobatics, but is that really what you're doing 90% of the time or more? No. Even me, routine cases are at least 80% of what I do. And so for most ophthalmologists, it's even more 90%. So really honing that technique here, making that incision. Look, we make that incision just right. And I'm using a steel keratome in this one to show you guys, since most of my audience uses steel keratomes, you can achieve a beautiful result. Here comes the rhexis. Going to make that nice round 5mm rhexis. We want that precise. And so we're going to make that just beautifully centered on the visual axis. Now we've marked the cornea off, the black ink marks there. We've marked that off at the cardinal meridians at 90 and 180. That little extra one dot that you see there nasally is just a piece of the ink mark that's floated off. It is not an insect or a bug. I've seen someone comment on this before. You're wrong. So here's the hydro dissection. Again, this is just a totally routine case. So we're tilting it slightly out of the capsular bag, which is great. Get that into a good position. Now, you don't have to prolapse it partially out of the capsular bag like this. It doesn't really matter. You saw that extra little aliquot of viscoelastic to help protect that corneal epithelium. Here comes a phaco probe. Going to adjust the tip there to get it the way I like it. And let's get that in the eye. We can just chop this nucleus right off the bat. Chopper's going to go around the equator. We just split it into two halves. Each half can be removed very easily. This is a routine case for me. Maybe 2+ nuclear sclerosis, not a very dense cataract. I think that one chop's probably going to be sufficient for the entirety of the case. At this point, my technician's already loading up the lens. And then we'll switch over to the eye probe for the cortex removal, and that lens will be ready to go as well. Notice how the chopper's in that safety position just to make sure the posterior capsule doesn't come up. If it does, it'll hit the back end or the smooth end of that chopper, and we'll take those pieces down. So very nice. You can see the outline of the incision there, a little bit of hydration of the stromal walls, and that incision really looks nice. You also notice that it made the incision 90 degrees away from the steep axis, right? So we can change the magnitude of astigmatism by a small degree with the incision, but we're not changing its direction. So if you make your incision on the very steep axis of the patient, on the cornea, on the steep meridian, then of course you'll minimize the astigmatism. If you make it on the flat axis, it slightly increases it, but it doesn't change its direction. So you can easily then account for that in a toric lens, which is what we're going to do in this case. So cleaning up all that lens cortex, that looks great. We'll get that capsular bag cleaned up nicely, polish up the undersurface here to remove that lens material as well. And then again, we'll get the lens in. So this is a routine case for me, definitely taking pride in what we're doing here. And I encourage you to do the same, especially if you're a young surgeon. Take pride in what you do and give your patient your very best. Every patient deserves that. So now we'll fill up the capsular bag here. We've optimized the red reflex in the video here so things look extra red, and that's normal. It just makes for a better video for when you're watching it there on your phone or your mobile device. And now here comes the lens. It's going to be a single-piece acrylic lens, a toric trifocal lens, what we're choosing in this case. And we'll get that delivered nicely in the capsular bag and rotated into a good position. So again, this is just a totally routine case, but I really tried to optimize every step of it. From the draping, you notice all the lashes are out of the way. The lid margin's fully sequestered. The eye's in good position. Notice how the eye's in primary. The iris is parallel to the floor of the room. I made the incision very precisely, and with good architecture, the incision will seal very easily with minimal hydration. The rhexis is just where we want it, very well centered, and 5mm in diameter. And now we remove the nucleus in a very safe manner, clean up the capsular bag. Here comes the lens. We'll get that precisely dialed into the meridian where we want it. And that really looks good. Remember, toric lens, it's trifocal. Line up the steep meridian with the toric marks, but also line up the central ring of that trifocal lens with the Purkinje images, first and fourth Purkinje images there. So sealing up the main incision, you notice it doesn't need that much hydration. So don't go overboard on the hydration there. That'll induce some astigmatism that's temporary, but still will give you a less than great result on post-op day 1. So now we'll do a sweep here, make sure we got all that viscosity out of the angle of the eye. That looks really good. And then let's get that centered up. It looks pretty darn good. I'll take this. That's a nice looking case. So at the end here, we'll do a little more sweep if you want, or seal up the main incisions. And again, we're going to check for positioning of the lens, which I'm very happy about. So a little bit more hydration here. That looks great. And now sealing up the incision with the tetracaine on a Wexel sponge. And we'll check with a dry sponge. Everything looks great.